Hi everyone, my name is Parshva Salvi. I am a third year medical student, and here I have a cool case for you that I saw during my rotation in cardiovascular surgery. So, here we have an interesting case of an 81-year-old female that was seen at Corwell Dearborn Hospital. She complained of shortness of breath that has worsened over the last month, along with some recent bouts of hemoptysis. She also endorses persistent cough and continued mucus plugging. She has a history of voluntary cough suppression as well. It should also be noted that she has an extensive pulmonary history, notable for ABPA and recurrent pneumonia of the right middle lobe. In terms of ROS, her constitutional is positive for fatigue, negative for weight loss, fever, and chills. For her pulmonary ROS, she is positive for cough, SOB, occasional hemoptysis, and her lungs are clear to auscultation and unlabored breathing. For cardiovascular, she is unremarkable, and for HINT, she is also unremarkable. Now, moving on to the histories, her past medical history is significant for ABPA, hypertension, recurrent pneumonia, and dizziness. Her past surgical history is significant for squamous cell carcinoma excision, hysterectomy, blepharoptosis repair, endoscopic sinus surgery. In terms of medication, she takes albuterol inhaler, fluticasone inhaler, Symbicort, Kenalog, amlodipine, rosuvastatin, and resveratrol. For allergies, she is allergic to ciprofloxacin, sulfa antibiotics, and ibuprofen. Her family history is significant for mother having hypertension, arthritis, and stroke, father having cancer of unknown type, and maternal grandmother having diabetes. For her social history, it's unremarkable, negative for smoking, alcohol, and drugs. For her vitals, she is hypertensive. She has a history of hypertension. She has a normal heart rate, normal respiratory rate. She is afebrile. Her height is 4'10, weight is 89 pounds. SpO2 is 97%, and BMI is 18.6. Her labs, CBC, CMP, and LFTs all are within normal limits. Her quantiferon test for tuberculosis was negative, and a BAL was done, and the fluid was sent for analysis, which grew strains of MSE. So, what do you think is going on with this patient after hearing the history? Please pause at this point and take a moment to come up with a list of differential diagnoses. Alright, so here's a list of differential diagnoses that I came up with. On the top of my list is pneumonia. She has had a history of recurrent pneumonia, so I'm thinking this could be another episode of pneumonia, so that's on the top of my list. She could also have lung cancer. She could also have ABPA. She has had a history of ABPA, so this could be another episode of it. And less likely, it could be COPD or sarcoidosis. To give you another clue, here's an image of the CT scan that was done on the patient. The CT scan showed pleural and parenchymal scarring, along with cylindrical and saccular bronchiectatic change that was most prominent within the lateral segment of the right middle lobe. So I would like you to pause again at this point and think whether you want to make a change to your differential diagnosis. Alright, to reveal the diagnosis, this patient has Lady Windermere syndrome. This is a very rare syndrome which is defined as Mycobacterium avium complex infection in the case of middle lobe bronchiectasis in an immunocompetent individual. And this syndrome is thought to be due to voluntary cough suppression. However, this is just a hypothesis and the exact cause is not known. And why does the Lady Windermere syndrome affect the middle lobes? It is because the middle lobes are narrow, long, and they have dependent bronchi with acute angulations predisposing them to infections. And this syndrome is classically reported in thin, elderly, white women. The diagnosis is made based on the clinical symptoms, along with radiologic patterns on CT scan and X-rays, and a positive MSE culture. In terms of treatment, the medical management consists of a 3-drug regimen consisting of azithromycin or clarithromycin plus rifampin plus ethambutol. Or if the medical management doesn't suffice, then they move on to the surgical management, which consists of a thoracoscopic lobectomy or a segmentectomy. Alright, so here are the references that I used in this article. If you enjoyed this presentation, you can have a look at these articles and learn more about Lady Windermere syndrome. Thank you so much for listening, and I hope you enjoyed it.